Hello, everyone. Thank you for joining and the San Antonio Breast Cancer Symposium Organizing Committee for inviting me. I would like to talk about the COVID 19 data response. And I think through this common tragedy that we all have suffered over the past 2 years, one of the silver lining is how the scientific community has come together, breaking down the silos and sharing data. Some of the things that we couldn't even imagine 2 years ago are now becoming routine, and I really hope this continues even beyond the pandemic. So, one of the articles that I read described COVID 19 data sets into basically four categories, whether they were individual level data or aggregate data, and whether they were controlled or open access. So, I would like to share my experience with two such individual level data sets, one of them being COVID 19 and Cancer Consortium or CCC19, and the other one is the Optum De Identified Electronic Health Record Database. So CCC19 is a grassroots organization that, believe it or not, started with one single tweet, and now it has snowballed into this massive, one-of-a-kind, largest registry in the world. The driving goal behind CCC19 being collection and dissemination of prospective, granular, and uniformly organized information on people with COVID-19 and cancer, and to collect it at, and disseminate it at scale and as rapidly as possible. Uh, as we see, the CCC19 currently includes 129 cancer centers across US and internationally, with more than 550 investigators from multidisciplinary teams, including oncologists, epidemiologists, biostatisticians, informaticians, patient advocates, and different healthcare providers and researchers, all with the common goal of identifying the impact of COVID 19 on cancer. And this organization includes a steering committee, again, with multidisciplinary experts from many institutions. It's almost a family now after sharing 2 years of pandemic emotions together. And I'm really fortunate to have been part of this group. The project coordination is at Vanderbilt University under the supervision of our PI, Dr. Jeremy Warner. We also have a scientific advisory and executive committee that provides us input and directions and counseling for future directions. So CCC19 data is collected through a centralized REDCap survey. This includes baseline forms which are only collected once, and then there are also follow-up forms which are collected on a repeated basis. So the baseline forms include demographics, predisposing conditions, comorbidities, smoking, BMI, concomitant medication, vaccinations, and COVID-19 illness includes symptoms, presentation, labs, severity, complications, co-infections, and clinical status. Cancer details are extremely extensive, as you can imagine. It includes type, stage, status, treatment details, toxicities, and various complications. And the follow-up forms include mainly COVID-19 outcomes such as hospitalization, mechanical ventilation, ICU stay, and mortality. And over the time, CCC19 registry has accrued more than 12,000 cases with more than 90% high analytic quality. So there's, again, a lot of informatic effort behind the scene, which continuously monitors the data quality and sends queries and updates the registry database to make sure we are producing high quality, rigorous research. And it has many sub-projects looking at various cancer sites, various research questions that we can utilize from the survey. One such is specifically looking at COVID-19, impact of COVID-19 on patients with breast cancer. And from 12,034 patients with cancer and COVID-19 diagnosed between March 2020 and June 2021, we identified 1,383 females with breast cancer and 25 females with 25 males with breast cancer. The hospitalization rates were 37% and 60%, and 30-day mortality was 6% and 20%. Although due to small numbers of male, these percentages might be exaggerated in this group. And utilizing the multivariable ordinal logistic regression modeling, we identified some of the prognostic factors that are associated with COVID-19 severity. So COVID-19 severity is defined as a 5-level ordinal scale, including no complications, hospitalization, ICU stay, mechanical ventilation, and mortality in that order. And what we identified is increasing age, minorities such as non-Hispanic, Black, Hispanic, Asian American, and others not categorized as non-Hispanic white had severe outcomes as compared to non-Hispanic white patients. Uh, the severity of COVID-19 was also associated with pre-existing conditions such as cardiovascular, renal disease, and diabetes mellitus. ECOG performance also had a strong impact on whether a patient experienced COVID-19 severity or not. Other factors included active and stable or active and progressing cancer, which was directly associated with COVID-19, with worse COVID-19 severity. What we did not identify was a statistically significant association between chemotherapy and targeted therapy after adjustment for spatiotemporal variations during the pandemic. So now switching gears to the other data set, the Optum is the Optum data set, which is a de-identified COVID-19 EHR database developed by the United Health Group that provides multiple services, including pharmacy benefits, health plans, data and analytic services. This de-identified individual data includes all the people who are identified with COVID-19, definite and probable between Feb 2020, and with and the data refresh occurs on a quarterly basis. It also has patients who do not have COVID-19, so they have negative tests. So that provides a nice avenue for doing case control studies. Now, the dataset includes inpatient and ambulatory care EHR records from more than 700 hospitals and 700 clinics across the US. It includes all eligible persons regardless of payer type. And there, as you can imagine, this is an EHR dataset including multiple data elements in age, race, ethnicity, other demographics, comorbid conditions, lab tests, vital signs, clinical measurements, and detailed information on procedures, medications, and administrative information. So again, a rich resource for understanding various questions related to COVID-19 in many different populations. We were specifically interested in understanding the outcomes of patients with or without cancer who were diagnosed with COVID-19. So we identified adults who were more than 18 years of age, and if they had COVID-19 diagnosis between March 1st, 2020 and June 22nd, 2021. And this was identified with lab confirmation through PCR test and cancer diagnosis before COVID-19 diagnosis. So some of the results for rates of complications in patients with COVID-19 include, as we see, we identified 509,500 patients with COVID positivity through PCR testing, and we identified 5% overall hospitalization and 3% 30-day all-cause mortality rate. Those who did not have cancer, the mortality was pretty similar as the general population, but if the patient had cancer and COVID-19, the mortality was was more than triple, actually 10%, and hospitalization was twice, 11% compared to 5%. Specifically in patients with breast cancer and COVID-19, what we saw was 30-day hospitalization of 8% and 30-day all-cause mortality of 6%. So there is a starking similarity in 30-day all-cause mortality between CCC19 and breast cancer and Optum breast cancer project. What is different is the 30-day hospitalization. And I think some of the reasons include CCC-19, we did not restrict hospitalization to 30 days. Also, there is difference in the type of centers participating in CCC-19, which is mainly academic centers, and Optum includes more clinics and more hospitals, so more community level data. So again, this underscores the importance of validation studies when using real world data. So, in conclusion, I think there's a huge debate whether randomized controlled trials are better or real world data is better. I think the question should be different. I think real world data has been used to answer epidemiological and clinical questions long before RCTs. And COVID-19 pandemic has demonstrated the urgency and importance of high quality real world data. Some of the large grassroots efforts, such as CC19 and EHR claims databases such as Optum, has shown that we can utilize these databases to answer questions quickly in a cost-effective manner. It is practical because we cannot expect to have randomized control trials for every question, and to understand how do we respond, what is the impact of COVID-19 of a new virus in the population. Having that availability of real world data set is really underscored. Some of the potential limitations of real world data include lead time bias, survivor bias, immortal time bias when we are comparing treatment intervention, also selection bias, which can also be seen in randomized control trials, and incomplete follow up and ascertainment bias. However, it is crucial to find data which is fit for purpose by analyzing breadth, depth, continuity of care, quality, and validation of the data set before we can be assured whether we are using the right data and the right study design to answer some of these questions. I think choosing the right study design is also important to help overcome some of these self-inflicted biases. And as we have seen, utilizing these latest innovative study designs has really helped us overcome some of these biases when using real world data. So together, availability of data as well as newer epidemiological and statistical methods can really help us answer many of the questions. It can really help us to understand what is the outcome, what is the impact of this new virus in vulnerable population, which we have seen are not typically included in the randomized control trials. And it also has a specific strength of being able to conduct studies which answer questions about incidence and outcomes and racial disparities. Again, where RCT may not be possible or may not be equipped to answer those questions. So, in conclusion, I think the question is not whether one is better than the other. I think the question is both need to be utilized. Both we need to invest in both of these, and having that availability, having that common organization and common goal of collaboration can really help us answer some of these questions and also prepare us for the next pandemic. Again, this is always a group effort, a team effort. We really would like to thank the patient and their families for sharing data, all the funding support that we have received, and all the participants from both the organization and both the teams. And I look forward to Q&A session. Thank you.